Now let's cover the non-hemolytic normocytic anemias. Anemia of chronic disease, or ACD, will occur in patients with chronic illness and inflammation. Inflammation leads to an increase in hepcidin, which blocks the release of iron from iron stores in macrophages. Thus, these patients will have increased iron stores, but insufficient iron supply to developing erythrocytes. Of note, if this occurs long-term, ACD can present like iron deficiency anemia and be microcytic and hypochromic. You can distinguish the two by looking at the ferritin levels, which tell how much iron is stored. What do you think the ferritin level will be in iron deficiency compared to ACD? In iron deficiency, it will be low, and in ACD, it should be high. Aplastic anemia is a condition where the myeloid stem cells fail or are destroyed. If you look at the marrow of someone with aplastic anemia, it's mostly replaced with fat. There is pancytopenia, meaning low red blood cells, white blood cells, platelets, and neutrophils. There are many different causes, including radiation, several viruses, DNA repair defects like Fanconi's anemia, and also immune etiologies. Symptoms will be related to the blood cell deficiencies. Low red blood cells will cause anemia, low white blood cell will increase susceptibility to infection, and low platelets will cause mucosal bleeding and petechiae. To treat these patients, you have to treat the underlying cause, but you can also transfuse in the short term to manage the symptoms, and give GCSF or GM-CSF to try to stimulate the bone marrow. The last non-hemolytic normocytic anemia is kidney disease, since erythropoietin is made in the kidney. Low erythropoietin leads to decreased hematopoiesis and a normocytic anemia. As I mentioned earlier, intrinsic hemolytic anemias are caused by something that's intrinsically wrong with the red blood cells that is causing them to be hemolyzed. Hereditary spherocytosis is a defect in the proteins ankyrin, band 4.1, or spectrin. These are structural proteins that stabilize the membrane. Affected red blood cells have less membrane, causing a loss of the biconcave disc shape and a loss of central pallor. The cells become smaller and rounder, hence the name spherocyte. The macrophages in the spleen continuously chew these red blood cells up, leading to splenomegaly, and the resulting anemia may need to be treated with splenectomy. A positive osmotic fragility test makes the diagnosis. These cells are more sensitive to osmotic pressure, so if you stick them in hypotonic solution, they swell up and pop more easily than normal red blood cells. G6PD deficiency was discussed in biochemistry, but in short, this X-linked defect in glutathione 6-phosphate dehydrogenase makes red blood cells more susceptible to oxidative stress, leading to hemolysis and anemia. Oxidative stress can come in many forms, including sulfa drugs, infections, favabines, some antimalarials, and dapsone. On a smear, affected cells will have Heinz bodies, which are made of denatured hemoglobin, and bite cells, which result from the red blood cells being chewed up by macrophages. Pyruvate kinase deficiency leads to a deficiency in ATP, which is required for sodium-potassium pumps to function, without which the cell holds on to too much solute and its volume expands, making the membranes more rigid and susceptible to hemolysis. Patients typically present with hemolysis as newborns. Sickle cell anemia is covered very extensively in the med school curriculum. It's an autosomal recessive disease, most common in the African American population, in which it has a prevalence of about 8%. It is caused by mutation in the 6th amino acid in beta-globin from glutamic acid to valine. Affected hemoglobin is designated HbS. Newborns are initially unaffected due to their predominance of hemoglobin F, but when these red blood cells begin to turn over, problems arise. Hypoxia and dehydration tend to trigger sickling and polymerization, leading to problems that can affect all areas of the body. If patients are affected with parvovirus B19, it can decrease erythropoietic activity, leading to an aplastic crisis. Autosplenectomy can occur, which increases risk of infection by encapsulated organisms like Streptococcus, Haemophilus influenza, and Neisseria. Sickle cell patients are also much more prone to developing Salmonella osteomyelitis. Do you remember the most common cause of osteomyelitis in non-sickle cell patients? That would be Staphylococcus. Painful or vaso-occlusive crises can occur when cells clump and block circulation, and these patients can also get renal papillary necrosis from papillary hypoxemia. Treatment for sickle cell disease is typically hydration, supportive care, and if needed, hydroxyurea, which increases hemoglobin F concentration, or in very severe cases, bone marrow transplantation is an option. Hemoglobin C defect is caused by a different beta chain mutation. These patients have a similar but milder disease presentation than sickle cell patients. Paroxysmal nocturnal hemoglobinuria is another cause of intrinsic hemolytic anemia. It occurs secondary to either a mutation in the GPI anchor or the decay accelerating factor in the red blood cell membrane. These proteins normally protect the red blood cells from complement-mediated lysis. You can think of complement as bombs that are constantly going off, but normal cells have these proteins to disarm the bombs. One test that's used to make the diagnosis is an elevated urine hemosiderin. The last category of anemias are the extrinsic hemolytic normocytic anemias. There are three main ways that they can be caused: autoimmune, microangiopathy, and infections. Autoimmune hemolytic anemia can be further classified as warm agglutinin or cold agglutinin. Warm agglutinin involves IgG antibodies against red blood cells that are seen with lupus, chronic lymphocytic leukemia, or drugs like methyldopa. Cold agglutinin involves IgM antibodies against red blood cells in the setting of mycoplasma pneumonia or infectious mononucleosis. Acute attacks are triggered by cold temperatures. There are a couple mnemonics you can use to help you remember these. One is that warm weather is great, to remember that warm agglutinins are associated with IgG, and cold ice cream, to remember that cold agglutinins are associated with IgM. A second mnemonic is the phrase colds, like mycoplasma and mono, cause IgM antibodies, because mono, mycoplasma, and IgM all have the letter M. Erythroblastosis fetalis is seen with Rh incompatibility. The mother develops antibodies against the fetal red blood cells. To diagnose autoimmune disease, you can use a direct or indirect Coombs test. The direct Coombs test looks to see if there are antibodies directly on red blood cells by adding anti-immunoglobulin antibodies to serum and testing for agglutination. If there are antibodies on red blood cells, then adding a secondary antibody will cause them to clump together or agglutinate. Indirect Coombs test looks to see if there are anti-red blood cell antibodies floating around by adding red blood cells to the serum and testing for agglutination. Microangiopathic anemias are caused by obstructed or narrowed vessel lumina that shear red blood cells. There are several etiologies: disseminated intravascular coagulation, or DIC, thrombotic thrombocytopenic purpura, or TTP, hemolytic uremic syndrome, lupus, and malignant hypertension. The key finding is the helmet cell, or schistocyte, on peripheral smear. As you can see, these cells look like they've been knocked around, or banged up. Macrohemangiopathy is the same idea, but with large, typically foreign objects cutting up the red blood cells. A common example is the prosthetic heart valve. Finally, some infections like malaria and babesia can also lead to increased destruction of red blood cells. This chart shows how understanding iron lab values can help you distinguish between different types of anemia. It is not necessarily important to memorize the exact normal lab values because they will be provided on the exam. It is, however, vital to understand what the numbers mean. Serum iron is self-explanatory. If you have low serum iron, you either don't have enough or are stockpiling it, such as in anemia of chronic disease. Transferrin transports iron in the body. It is a good measure of how much the body is trying to get at the available iron. The body mobilizes as much iron as it can in iron deficiency, so transferrin is high. But in iron overload, or ACD, the body is trying to reduce serum iron, so it expresses less transferrin. The reason the body wants to decrease serum iron in disease states is because pathogens need iron too, so by decreasing it you are preventing pathogens from getting it. With pregnancy or OCP use, transferrin goes up, because you want to make sure you provide enough iron to the fetus. Ferritin is a measure of how much stored iron there is, and as mentioned earlier, it is the best way to distinguish iron deficiency from ACD. In iron deficiency it'll be low, whereas in ACD it'll be increased. Transferrin saturation is a way of looking at the iron to transferrin ratio. In iron deficiency, you have low iron and high transferrin, so transferrin saturation will be low. In hemochromatosis, you have high iron and low transferrin, so transferrin saturation will be very high. Lead poisoning is similar to hemochromatosis as far as iron lab values. Since lead poisoning inhibits erythrogenesis, you have leftover iron in the serum, and therefore transferrin is reduced and transferrin saturation is high. Let's take a look at the pathway for heme synthesis. This pathway is a good one to memorize, as it will help you keep the porphyrias straight. As you can see, glycine and succinyl-CoA combine to form delta-aminolevulinic acid via the enzyme DALA synthase. Don't forget that this is the rate-determining step for heme synthesis. DALA is then converted to porphobilinogen via DALA dehydratase. Inhibition of ALA dehydratase is the first pathologic effect of lead poisoning. Porphobilinogen is then converted to hydroxymethylbilane via the enzyme porphobilinogen deaminase. This reaction is important because deficiency of the active enzyme leads to the second most common porphyria, acute intermittent porphyria. The next important reaction is the conversion of uroporphyrinogen 3 to coproporphyrinogen 3 via the enzyme uroporphyrinogen decarboxylase. Deficiency of this enzyme leads to the most common porphyria, porphyria cutanea tarda. After a few more steps, protoporphyrin joins with iron to form heme via the enzyme ferrochelatase. Lead poisoning can also block this last step in heme production by inhibiting ferrochelatase.